Good afternoon, everyone. My name is Robin Yabroff, and I am a Scientific Vice President of Health Services Research at the American Cancer Society. I want to welcome you to this webinar. We've had a lot of interest in this topic related to utilizing simulation modeling to inform cancer control in responses to the COVID-19 pandemic. So a brief overview of our discussion objectives. We're going to be talking about the CISNET models. We're going to ask some of the CISNET modelers to describe some of their latest findings on the effects of pandemic-related disruptions in colorectal cancer, cervical cancer, and breast cancer outcomes. We'll also be considering strategies for recovery and advancing cancer screening during the presentation. We have a lot of material to cover today, as you can see in the agenda in this blue portion of the slide over here, including an overview that I will be giving, presentations, and questions and answers during the panel discussion. Many of you are aware of a editorial published by Dr. Ned Sharpless, the director of the National Cancer Institute, about the effects of the COVID-19 pandemic on cancer care and outcomes in June 2020. And here you can see, this is a figure from that editorial, that modelers projected 5,500 excess breast cancer deaths and 4,500 excess colorectal cancer deaths, during the decade between 2020 and 2030. We're really excited about the panelists we have today. And I want to just list them out and also remind you that I'll be giving longer bios as we go through those presentations. So we're going to start with Dr. Eric or Rocky Foyer, Dr. Iris Lansdorf-Vogelaar from the CISNET Colorectal Working Group, Dr. Emily Bulger from the Cervical Cancer Working Group, and Dr. Oz Alagos from the Breast Cancer Working Group. And before we start, though, I want to reflect a little bit on progress. So cancer mortality rates really have been declining in recent decades in the United States due to advances in cancer prevention, screening, and survivorship care. And you can see here in this next figure, trends in cancer death rates in the United States between 1975 and 2018. You see large declines in both males and females, and it's about 31% decline from 1991 to 2018 for both sexes combined. And at the same time, it's really important to recognize some of the many disparities. For too many individuals for whom screening is recommended, they remain unscreened and they're also unable to access effective care that could save lives. Today, we're really going to be focusing on the consequences of the COVID-19 pandemic. And as noted earlier, there's increased cancer mortality. So the pandemic-related reductions in healthcare access and cancer screening resulted in a short-term drop of cancer diagnoses and a corresponding increase in late-stage cancer diagnoses and potentially preventable deaths. There have also been increased disparities, and the pandemic continues to exacerbate not existing social and economic disparities. And these are disproportionately affecting disadvantaged and underserved populations. Enterprise-wide, the American Cancer Society and the American Cancer Society Cancer Action Network have organized mission priorities and program work to effectively correspond to the consequences of the COVID-19 pandemic. And there are 6 building blocks to this. There's a national consortium, public awareness campaign, targeted research, state and coalition, healthcare systems, and of course, public policy, pursuing those policy solutions that can benefit all during the pandemic. I'd like to acknowledge, or at least mention, some of the ACS enterprise-wide screening initiative that is supported by generous contributions from several funders, including Genentech, Pfizer, Merck, Novartis, and the National Football League, as well as partners as part of the National Consortium. And that National Consortium, which is sponsoring this webinar, is an issue-focused, time-bound partnership dedicated to accelerating a national response to the COVID-19 pandemic. Before we start though, I have some virtual housekeeping I'd like to review with you. The event is being recorded and the replay and slides will be made available in a couple days. Because of the broad interest in this topic, all participants are muted. But I do encourage you to participate in general discussions via the chat and also to use that Zoom Q&A box throughout the webinar for questions. We're interested in continuing to improve the quality of these webinars, so please complete an evaluation for future feedback. And then also save the date for the next webcast, which is going to be Thursday, September 9th. With that, I will stop sharing my own screen and invite Dr. Rocky Foyer to share his screen. So as he is loading his slides, I want to note that Dr. Foyer is the chief of the Statistical Research and Applications Branch in the Surveillance Research Program, the Division of Cancer Control and Population Sciences of the National Cancer Institute. And I will note that this is the program where the SEER Population Cancer Registry data comes from. He is the founder and the NCI project scientist for CISNET. Rocky, welcome and thank you.
Thank you. I'm going to talk about an introduction to population modeling to guide public health research and priorities, and more specifically, NCI CISNET Consortium. The Cancer Intervention and Surveillance Modeling Network, or CISNET, is the NCI-sponsored collaborative consortium of modelers in breast, prostate, colorectal, lung, esophagus, and cervical cancers. It was formed in 2000, and these are competitive grants renewed every 5 years. The overall purpose of CISNET is to synthesize trial, epidemiologic, and surveillance data using simulation modeling to guide public health research and priorities, and to help address what's sometimes called the formidable and growing gap between the rapid pace of innovation in cancer research and our ability to efficiently harness it to improve population health, and to provide a link between complex evidence and actionable public health strategies. In many instances, individual modeling efforts yield different results that are difficult to reconcile, and this has caused considerable credibility issues with respect to this kind of modeling. The approach innovated by CISNET is a systematic comparative modeling approach where we have central questions to be addressed by groups collaboratively with a common set of inputs and outputs, where reproducibility across models adds credibility to the results and differences points out areas for further study in a very systematic way. Probably the most high-profile work has been in assisting the U.S. Preventative Services Task Force in developing screening guidelines for colorectal, lung, breast, and cervical cancers. For example, the CISNET Lung Group extrapolated from the only major lung cancer screening trial at the time, the National Lung Screening Trial, to hundreds of different regimens of screening, modifying the age to start screening, the age to stop screening, and how many pack years of smoking someone should have to be eligible. And because of the difficulty of assessing credibility issues associated with individual modeling efforts, prior to CISNET, the task force rarely used modeling to supplement its usual direct evidence reviews. The organization for CISNET focuses on 6 multiple PI grants, for each focused on a different cancer site, 6 cancer sites, 6 grants, each with a coordinating center, and between 3 and 6 independently developed modeling groups. The framework for CISNET models starts with common inputs: risk factor trends, screening behavior, diffusion of new treatments. Then it moves on to individual cancer simulation models. This is the heart of CISNET, as I mentioned, between 3 and 6 independently developed models per cancer site. Now, unlike real life, we simulate individual lives multiple times. In other words, parallel lives in the presence and absence of interventions, and compare the results. For example, as if the pandemic never occurred, and if the pandemic occurred and people delayed screening or treatment in accordance with certain assumptions. And we call these different versions of someone's life counterfactuals. The modeling starts with demographics in early life, sex, race, year of birth, and development of risk factors, and then moves on to preclinical cancer, precancerous lesions, and tumor initiation and growth. The preclinical natural history of cancer, for example, when does breast cancer develop and how long does it take to cause symptoms, isn't directly observable and has to be indirectly inferred from screening, autopsy, and other studies, which provide a glimpse into the preclinical natural history of cancer. And this represents one of the major challenges of CISNET modeling, And the varied approaches to modeling natural history represents a real strength of the comparative approach. This preclinical history of disease is relevant in the context we're going to talk about today, because as people delayed screening before the pandemic, we need to simulate if they would have been diagnosed through symptoms before their next screen, what that might mean in terms of their prognosis, and eventually how many more people would die of their cancer in their lifetime as a result of this delay. The modeling moves on to post-clinical cancer, the diagnosis of cancer and treatment, and then death from cancer or other causes. Then, summing together the individual histories, again in the presence or absence of interventions, we can model the harms and benefits of interventions. For example, mortality, quality adjusted life years, overdiagnosis and direct medical costs, etc. And then by modeling multiple birth cohorts, we can represent the real US or other populations over time. As an example of risk factor trends inputs into the model is the smoking history generator developed by the CISNET lung group based on national health interview surveys since 1965. The cancer model talks to the smoking history generator and feeds it the year of birth and the race and sex of the person being simulated, and queries the smoking history generator for the age of initiation of smoking if they started, how many cigarettes per day they smoked, and the age they quit if they quit. Most relevant to the talks today are screening history generators that, given a person's year of birth, simulates the age where they had their first screen, how often they've had subsequent screens, and for some cancers, such as colorectal cancer, what modality of screening they had. Finally, I want to mention that CISNET was very proud to receive the Society for Medical Decision-Making 2020 John Eisenberg Award for sustained leadership in translating medical decision-making research into practice and communicating findings of medical decision-making research to policymakers, clinical decision makers, and the general public. You're now going to hear from 3 different cancer modelers who have been investigating the impact of the pandemic on cancer outcomes. Thank you.
Thank you, Rocky. Next up, we have Dr. Iris Lansdorp-Vogelaar. She is an associate professor at Erasmus University Medical Center in Rotterdam and in the Netherlands. She is the multi-PI of the CISNET colon working group and has been an active member of CISNET since 2003. Take it away, Iris.
Thank you very much, Robin, and thank you very much for the opportunity to present to you today some of the work that we've been doing looking at the impact of the COVID pandemic on colorectal cancer screening. And unlike the other presenters today, I will actually be giving a global modeling perspective, since this is work that we've been doing as part of the COVID and Cancer Global Modeling Consortium. It probably doesn't surprise you that the impact of COVID on cancer is not just isolated to the US, but is actually a worldwide problem. And this slide is just meant to give you an idea of what the impact of the pandemic has been in the Netherlands. In the blue line and the red lines, you see the diagnosis of all cancer sites, excluding skin cancer in blue, and in the red line, only skin cancers, and what happened to those diagnoses, especially after, in the red bar, around half March, nationwide implementation of strict social distancing policies happened. And you see that the impact of that was not just that we were restricted in our freedom, but also that there was a huge drop in diagnosis of cancer. And if we would look at these, this is for all cancer sites combined, but if you would look at these numbers for the screenable cancers, and especially within the screening age, then you see even more dramatic drops than you see in this picture. An informal survey among programs across the globe showed that by March or by April, 23 out of 28 surveyed colorectal cancer screening programs had suspended their screening at that time. And even the programs that did continue, those programs suffered from lower capacity or lower participation with screening. And this really raised questions about how we could mitigate the long-term impact of these disruptions for colorectal cancer screening and mortality. And in light of this question, the COVID and Cancer Global Modeling Consortium was started. And this consortium consists of 3 working groups that look at different impacts that COVID has had on cancer in general. The first working group is looking at what the direct impact is of the infection on cancer outcomes and treatment services. So are people that are diagnosed with cancer more likely to contract COVID and therefore do their prognosis worsen, or the other way around? Is there an impact of contracting COVID on your cancer treatment? The second working group is looking at the impact of the pandemic on cancer screening and recovery strategies. So that's the working group that I've been most involved in and what I'm going to share some first results on today. And finally, this third working group is looking at the indirect impact of the pandemic on cancer risk. We all know that because of the pandemic, we were constrained to stay more inside, and actually people started moving less, started drinking more, started smoking more, at least in some parts of the world. And this also has an impact on cancer risk. So that's what the third working group is working on. And each working group now is sort of working independently, but the idea is that this work will eventually be combined so that we can look at the joint impacts of all of these different outcomes. Today, I want to share you some results of the colorectal cancer screening working group that was part of working group 2. And we've actually already done 2 projects with this group. Project 1 had the aim to evaluate what the impact of the disruptions to colorectal cancer screening during the COVID pandemic had. And we were looking at several scenarios. We were looking at complete suspension of programs for screening of 3, 6, or 12 months. And we also looked at different scenarios of possible reductions to screening participation after these disruptions, as well as possible catch-up screening scenarios for people who missed the screening due to COVID-19. And in this analysis, we used 4 microsimulation models, ASCA, Miscan Colon, OncoSim, and Policy 1 Bile, to evaluate the screening programs and these scenarios for screening programs in the Netherlands. That was the first 2 models, Canada, the third model, and Australia, the last model. And if we look at the long-term impact of these scenarios, we first are going to consider various disruption lengths. So we modeled disruptions of 3 months, 6 months, and 12 months. And in the left graph here, you see the additional colorectal cancer cases that we would expect based on the modeling between 2020 and 2050 for the 4 different models. And you see that sort of the impact on the additional cases is proportional. So the longer the disruption, the more additional colorectal cancer cases you will have in each country. And similarly, we see that in the right-hand graph for the colorectal cancer deaths. And you see that there are differences in the impact that the models predict, which have to do, of course, with maybe differences in modeling, but also, and maybe more importantly, differences in country settings. For example, in Australia, the screening program uses 2-sample fit screening, whereas the screening programs in the other countries use a 1-sample. So the impact of screening is higher, so the impact of a disruption of screening may also be higher. But in general, the models were very consistent in that disruption should be kept to a minimum to avoid the largest impact of the disruption due to COVID. If you want to do something about minimizing the long-term impact, we looked at additional scenarios. So again, for each model in the blue, the dark blue on the left, you see the impact if you only have a 6-month disruption with no other effects, and you assume that all of those people that were due for screening during the 6 months do not receive any screening at all. However, if you, in addition to that 6-month disruption, will also have another 6 months of reduced participation, then you see that the impact of the COVID pandemic almost doubles. And if you look then at what would happen if you would have a 6-month disruption, but then you would be able to immediately catch up all the missed screens within the 6 months after that, then you actually see that the columns disappear. So you don't see the results except for Policy 1 Bile Australia, which means that you're able to completely mitigate that long-term impact of the additional colorectal cancer cases and the additional colorectal cancer related deaths from that COVID pandemic. So this was a very important message that was very consistent across the 4 models. If you're able to catch up screening, you can really mitigate the impact of the pandemic. So that was very good news. In the second project, we wanted to dive into that a little bit more because, of course, we realized that catching up screening was a good strategy to do, but we also knew that many countries, despite that the screening programs had restarted again, were still suffering with a lack of capacity to perform the full programs. They, on the one hand, had to invite the people that they were used to inviting, but they also had to clear the colorectal cancer screening backlog due to that disruption. And therefore, we wanted to see, okay, given that we have limited resources, what is the best way to try and catch up? And therefore, we simulated scenarios. These are all FIT screening programs, so using a fecal immunochemical test. And one set of scenarios looked at doing the FIT as usual and trying to catch up all the individuals either within 6 months, 12 months, or 24 months to be back on schedule by 24 months or 12 months or 6 months. And the other scenario was looking at 6, 12, and 24 months, but trying to increase your threshold for a positive FIT so that you had fewer colonoscopies and so maybe could screen more individuals. And the levels that this threshold was set to were based on what was currently done in the program. And again, we use those same 4 microsimulation models to see what worked best. Here I'm only presenting you the results of one of these models. This is our own model, the miscan colon model. And what you can see here, and this is quite a complicated graph, so I'm trying to go through it slowly. But in the left panel of this graph, what you see is the additional colonoscopies that you need during that recovery period to try and catch up your individuals. And each bar represents a different threshold for a positive test. And so what you see, if you take, for example, the top bar, you see that if you want to catch up all of the missed individuals that were disrupted for a 3-month period within the 6 months after that, then you would require 50% more colonoscopies during that recovery period. However, if we go to the second bar that has been aligned, if we would catch up in 12 months rather than in 6 months, you would only require 25% additional colonoscopies per month, which might be more doable. And even if you go to 24 months, you would only require an additional 10% of your colonoscopies per month, which is even more doable maybe. And still, if you look at the effect, so what you can do, there is some excess deaths if you don't catch up. And if you immediately catch up, that's the top scenario, then you see that you can prevent 100% of those excess deaths. But what you see here in the 24 months recovery, although you're spreading out people more and there's more people with a delay, you're still able to catch up almost 90% of your excess deaths. So you're still able to prevent those excess deaths. However, 10% extra colonoscopy demand may still be an issue for some countries that are still struggling. And then you could consider an alternative. For example, this scenario that's been highlighted here requires only 5% additional colonoscopy demand, and you would still be able to mitigate 50% of your excess deaths. And so these scenarios can help inform countries to make a good decision about what scenario to do to try and catch up these missed individuals. So these analysis were obviously not done for a US setting, but still there's a lot of things that you can learn from these analyses also for the US setting. So to try and mitigate the impact of disruptions of screening programs, what we show is that it's very important to keep the disruption as short as possible. If you're not able to fully mitigate the disruption, try to catch up screening of all the missed individuals, and it is not a problem if that takes a little bit longer. And what's also very important is to try and facilitate and promote participation to screening after these disruptions. So now that the most COVID waves hopefully have been taken, let's try and get people back to screening again. And especially in light of disparities, we all know that the COVID pandemic has done much more than disrupt screening. A lot of people have lost their jobs and maybe their insurance. So it's very important to try and see if we can keep these people participating with screening, because otherwise this would further increase the disparities in this field. And if there is insufficient capacity to immediately catch up everybody, try to catch up the people over an extended period of time is the best alternative to do. Of course, there's some limitations to this analysis. The models that we used in this analysis differ quite in structure, natural history assumptions, and screening parameters. So it's very uncertain to what extent some of the differences that you see between the models are driven by model differences and what because of the differences in design of the screening programs. Yet the models were very consistent in the conclusions, so that reassures us that this is a robust conclusion. And these analyses so far have only looked at the impact of screening, and we haven't taken into account the additional impact of delays in treatment yet. However, in a prior analysis that we did at CISNET for Dr. Sharpless, we show that these effects are actually synergetic, but then in the bad sense, in the sense that if you have both delays in screening and delays in treatment, the combined effect is larger than the sum of the individual effects. So there could be even worse impact than we are projecting in these trends. The good news is that the data seems to be confirming what the modeling has predicted so far. So this is colorectal cancer incidence in the Netherlands between January 2020 and May 2021. And you see indeed in March, there's a huge drop in the diagnosis of colorectal cancer, especially in the age group that is going to be invited for screening between 55 and 75. But the good news is, when in October we started inviting more individuals, so over-inviting individuals to catch up those missed screens, and that has been happening between October and May, that indeed we see that we are catching up those misdiagnoses, and hopefully, and that's the next step of the analysis that we're going to look at, still in time to have a preventive effect. With that, I want to acknowledge my colleagues in this global consortium, and I want to thank you for your attention.
Thank you so much, Iris. Next up, we do not have any clarifying questions. So next up, I'm going to introduce Dr. Emily Berger. She is an associate professor at the University of Oslo and holds a joint appointment at the Harvard T.H. Chan School of Public Health. She's been a co-investigator of the CISNET cervical working group since it was added to CISNET in 2015. Welcome, Emily.
Hi, thank you so much. I'm pleased to be here and present some published and also some preliminary results from our CISNET cervical group. So sustained COVID-19 related disruptions to cervical cancer screening process may not only delay an individual's primary screening test, but may also interrupt downstream processes for individuals in need of surveillance, diagnostic colposcopy, or even treatment to remove precancerous lesions. Over the last 18 months, CISNET and, as Iris described, the CCGMC cervical teams have undertaken several projects, two of which I will highlight today. So for the first project, which was initiated at the beginning of the pandemic before empirical data were available, we used 3 of the models from CISNET cervical working group to quantify potential cervical cancer screening related impacts of alternative COVID-19 related care disruptions, stratified by the primary screening modality, duration of the disruption, and step in the screening process that's being disrupted. The second project, for which I only have some preliminary results to show, used these same 3 models to quantify the health impacts associated with different temporary disruption periods to primary screening services. But we looked at this by the time since a woman's last screen and her age. The second project was really motivated by the heterogeneity in primary or routine screening frequency to help us understand how COVID disruptions may impact women differentially, potentially leading to widening disparities. For project 1, we considered 8 alternative disruption scenarios that varied by the duration of the disruption, so either 6 or an upper bound of 24 months, and the step in the screening process being disrupted. So we disrupted all screening steps, including temporary disruptions to primary screening, surveillance, colposcopy visits, and excisional treatments, or disruptions to 3 of these screening steps, just 2 of the screening steps, or where only primary screening was disrupted. We layered on these screening steps incrementally in order to isolate the impact of that screening process to inform priority groups for post-COVID reintroductions. We assumed 100% of the women experienced this temporary delay, but the screening process resumed completely following the disruption period. We simulated these disruptions under 2 primary screening modalities, as there's a mix of primary screening use in the US. So women aged 21 to 65 were screened either using pap smear alone throughout their lifetime, or were assumed to switch to co-testing at age 30. Screen positive women were managed according to guidelines, and the scenarios were simulated in the context of both historical HPV vaccination coverage and Kaiser Permanente Northern California screening practice patterns. And although recommended, we did not explicitly evaluate primary HPV testing alone, but I'll be able to speak to that when I present our findings. As I turn to the results, I'm showing the change in absolute cancer cases per 1 million women screened on the y-axis, by time and years on the x-axis, associated with a 6-month delay for our Harvard model only. As shown by the legend on the top, PAP-based screening is shown by the stapled lines, and co-test-based screening is shown by the solid lines. And then the different colored lines reflect the different steps in the screening process that we're disrupting. So you can quickly see that these scenarios largely overlap with a 6-month disruption on the current scale. However, the trends show that compared with the scenario without a COVID delay, the Harvard model projected that there will be initial decreases in cervical cancer detection during the estimated 6-period disruption period, followed by an increase in the rates after the disruption period. So these trends hold for both primary screening modalities. And the surge in cancers in 2021 could be thought to be from a mix of cancers not detected in 2020, but also a few additional cancers because women may have missed an opportunity to be screened and to remove a precancer that progressed during the disruption. These patterns were consistent in the other 2 models. Note that the MISCAN model in the middle reported only outcomes for delays to primary screening shown in by the yellow lines. But if we do focus on the middle panel for the MISCAN model, we can more easily see the small differences between the detection fluctuations by primary screening test. For women whose last test involved PAP alone, these women faced a greater increase in 2021 than those women whose last test involved a more sensitive HPV test. Across our scenarios, using HPV testing was always able to better absorb the impacts of the delays. These decreases and increases in detection were, of course, more exaggerated for a 24-month disruption period shown by the 3 panels on the bottom. And the importance of screening modality and the number of screening steps disrupted became more important with the longer delays. We can also see that the delays to primary tests shown in yellow were generally smaller than the delays to all 4 steps in the screening process that's shown by the purple line. Ultimately, while it's important to understand shifts in the timing of diagnoses, we wanted to see if these oscillations resulted in excess number of cancer cases compared with no COVID. So when we looked at the projected additional number of cases per 1 million women over this entire short-term period for the Harvard model, which is in the left panel, and the Policy 1 cervix model on your right, we see that the projected 6-month disruptions yielded small but greater net increases in cases among women screened with PAP alone compared to those women screened with co-testing. And you can train your eye on the left bars for each panel compared to the ones directly to their right. And again, these are not surprisingly greater for a 24-month disruption, but patterns in screening step and the screening test became more pronounced. Cumulatively, by 2027, 6-month disruptions to all screening process steps under the PAP screening were projected to increase the number of cases between 5 to 7 per 1 million women screened, and then up to 38 to 45 additional cases per 1 million screened for the longer 24-month disruption. What I think is an important message here is that compared to using PAP alone, delays for women with a previous co-test, or arguably HPV testing is the driver here, resulted in fewer additional cases, particularly those stemming from disruptions to primary screening, shown by these yellow bars, rather than these downstream steps. So if you think about it in a reverse, we estimated that 60 to 75% of these additional cancer cases were due to disruptions to ongoing surveillance, colposcopies, or excisional treatment. That is these green, the blue, and the purple bars. So hopefully this, sorry, I just jumped ahead. If you continue services for these women or prioritize them to return, the impacts of the delays are greatly reduced. The final table for this project 1 shows the proportion of women in our models disrupted for each screening modality by step in the screening process. For example, in column 1, our model finds that 69 to 80% of the women are on or considered to be on a routine screening schedule, which means that you can target capacity or constrained capacity resources to the relatively small proportion of women in need of surveillance, colposcopy, and treatment, and prevent the majority of our projected additional cases. What we didn't do in this first analysis is stratify those women who are on a primary screening schedule to look at those women who are either overdue compared to those women who attend screening regularly, which led us to undertake a second project. So as I've talked with screening program managers, there's been a general sense of relief when a generic coverage metric is returning to pre-pandemic levels, which is certainly important. However, with this next analysis, I wanted to emphasize that if there is a small proportion of women not returning, and these women are at higher risk, the same disruption period may differentially impact these women and disparities may widen. To set up this analysis, we assumed that in the absence of COVID, each cohort would have received a primary screen in 2020, but they're coming into that primary screen with an underlying screening history. That is, it's been 1, 3, 5, or 10 years since her last screen. And whether a woman is up to date on screening can often be correlated with race and ethnicity, poverty income level, education, and insurance status. While our models are agnostic to these characteristics specifically, these characteristics are associated with screening behavior, which our models can currently reflect. So these women then face, under different scenarios, either no delay, a 1, 2, or at the very extreme, a 5-year delay. For this analysis, we quantified the interactions between a delay and then time since a woman's last screen. This graph shows the lifetime risk of developing cervical cancer on the y-axis by screening frequency on the x-axis, assuming pap smear-based screening. Anchor on the 3-yearly black bar, which is the no delay scenario and what we would call a guidelines-based screener. So a woman screening every three years with cytology. A woman who screens more frequently would be considered an over-screener to the left, and then 2 categories of under-screeners under cytology. So that's a woman screening every 5 years or every 10 years all the way to the right. The main driver of lifetime risk is screening frequency. If you look at the green, turquoise, and dark blue bars, for a given screening frequency, which reflect the increasingly longer temporary disruptions to screening, you can start to see some delineation and risk between the height of those bars as the duration of the delay increases, particularly for these women experiencing with a 10-year screening history. When we zoom in on these incremental differences between each one of these bars, now shown on the bottom panel, oops, there we go. A 1-year delay. Oh, sorry. So, right. So if a 1-year delay has almost no impact on an annual or a three yearly screener, right? You don't see any excess risk being generated in the green bars here. While an annual delay or longer increases the risk disproportionately, the longer it's been since her last screen. So for example, a 5-year temporary delay is projected to increase the number of cervical cancer cases by 31 per 100,000 women with screening under cytology every 3 years, while we project 44 additional cancer cases per 100,000 women, screening with cytology every 10 years for this exact same 5-year delay. Importantly, our analysis did not quantify the number of women and family members who might acquire COVID as a result of screening-related visits. We also assumed that all women faced delays and that screening services resumed immediately following the disruption period. While this assumption was not realistic, we're more able to precisely quantify the health consequences of the period of the delay without conflating the uncertainties of more nuanced and local reintroduction of services. So our projections provide benchmarks, that is like an upper and a lower bound for setting specific calculations. Importantly, while we evaluated the impact of potential delays to precancerous treatment, we did not evaluate the impact of potential delays to cancer treatment. Based on the estimates from other studies, however, delays in cancer diagnosis may likely have a greater impact on the lives lost than disruptions to cervical cancer screening alone. So the take-home message from our US-based analyses is that we consistently found that temporary suspensions in cervical cancer screening pathway may potentially result in temporal shifts in cancer detection and yield small net increases in cancer burden between 2020 and 2027. Compared with other cancers with more expedited natural histories, those that may progress more quickly, the impact of temporarily disrupting cervical cancer screening appears lower. Our independent models consistently predicted that prioritizing reintroductions of services for women in need of surveillance, colposcopies, and treatment, excisional treatment, as well as women whose last screen did not involve HPV testing, may mitigate the majority of potential secondary impacts of COVID-19 on cervical cancer. And then lastly, from our preliminary results from Project 2, the main driver of lifetime risk of developing cervical cancer is screening frequency, rather than a temporary disruption to screening due to COVID. However, a disruption does not equally impact women with differential screening histories. Self-sampling or home-based HPV testing may provide a tool to reach the women most vulnerable to screening disruptions with infrequent screening histories. In the Netherlands, self-sampling is already available to women who are overdue for screening, and preliminary findings suggest that this has facilitated rapid reintroductions of screening in the context of COVID-19. And with that, I'd like to thank everybody.
Emily, that was excellent. I'd also like to thank the audience members who have submitted some questions that will give us a preview of what we'll be talking about during the panel. But before then, I want to introduce our final modeler speaker, Dr. Ozhan Alagaz. He is a Procter & Gamble Bascom Professor of Industrial and Systems Engineering at the University of Wisconsin-Madison. He's been a member of the CISNET Breast Cancer Working Group, is co-leading the University of Wisconsin breast cancer simulation model since 2007. Welcome, Oz, and I'm looking forward to your presentation.
Okay, thank you, Robin. And hello, everyone. I am Oz Alagaz, and I'm going to share our findings from a recent analysis that estimated the effect of pandemic on breast cancer mortality in the United States. So I'm going to start with presenting two graphs that show how pandemic disrupted breast cancer control use. The first one is from Epic Health Research Network, which shows that how mammography screening changed in 2020 compared to the levels in pre-pandemic years. And as you can see from this graph, over the time, there was a huge impact of pandemic. In April 2020, there was a 94% drop in mammography screening. And although over time by summer of 2020, mammography screening gradually improved, there were still some deficits. By June 2020, mammography screening volumes were 30% lower compared to the pre-pandemic levels. So this is the impact on screening. The second graph shows another effect of pandemic on breast cancer control, which is symptomatic diagnosis. So this graph includes data from two cancer surveillance systems, both members of Breast Cancer Surveillance Consortium, BCSC. And it shows that women presenting with symptoms for diagnostic imaging decreased by 21% in Vermont and 45% in San Francisco registry, during March and June 2020 compared to the pre-pandemic levels in 2019. So what do these data tell us? And there is a lot of other reports that show that there have been short-term impacts of pandemic on breast cancer control activities, yet there is limited information on the long-term impacts of these disruptions, and this is what this study is about. So we used 3 CISNET models, and we projected the effects of these disruptions that mostly occurred within the first 6 months of pandemic on breast cancer mortality. And we focused on 3 components of breast cancer control. First, screening disruptions, for which we use EPIC data. Second, delays in diagnosis, for which we use data from BCSC. And the third one is reduced chemotherapy, for which we use expert opinion, as there is a lack of reliable and good data. Okay, so in doing this analysis, we used the same assumptions that are used when we did a modeling study for US Preventive Services Task Force back in 2016. In summary, we used the following settings in our scenarios. We focused on breast cancer mortality as an outcome, and we simulated everybody alive in 2020. And we used the latest mammography performance data from BCSC, and we assumed that treatment and screen dissemination is extended to the future as it is recently. Now, here are the scenarios that we considered in this study. As Raki said, these are our parallel universes. Our first parallel universe is there is no COVID impact. And in this case, we assume that everything goes as usual. Screening, diagnosis, treatment would have been the same as in 2019. I wish we were living in this universe, but we are not. So the first scenario that we considered is looking into the reduced screening, in which, based on EPIC data, we assumed that 50% of the women missed their exams during March and September 2020 periods, and half of these women make up their exams in 6 months, whereas the other half skip their exams entirely and wait for their next scheduled exams, which could be 1 year later or 2 years later, according to the mammography dissemination model. And the second scenario is a delayed diagnosis scenario. Here, using BCSC data, we assume that 25% of the women who would normally be detected via symptoms delayed their diagnosis for 6 months. The third scenario is the reduced treatment scenario. And again, here we used an expert opinion. We assumed that women who are diagnosed with ER positive, HER2 negative, and stage 1, 2A cancers, they received reduced chemotherapy, and the reduction was higher among women over age 70 compared to women younger than age 70. And we also assumed here that there was no reduction of chemo for other cancer types, stages, and no reduction in endocrine therapy, surgery, or radiotherapy. And finally, we considered joint disruption scenarios. Now, I'm going to show you the results. And remember that we ran 3 models, so we actually have results from 3 models, but I'm only going to present the results of the model that provided the median results. In this case, it is our Wisconsin model. So we found that by 2030, reduced screening alone would lead to 950 excess deaths. Delayed diagnosis alone would lead to 1,300 excess breast cancer deaths. And reduced chemotherapy alone would lead to 151 deaths. And if you consider reduced screening and delayed diagnosis, together they would lead to an additional 2277 excess deaths over the next 10 years. And all 3 disruptions, the models estimated that would lead to an additional 2487 deaths, which corresponds to 0.52% increase compared to the no pandemic scenario. And this graph shows how additional deaths are projected to occur over time. And here the turquoise line shows the excess deaths corresponding to the disruptions in screening scenario. Red line is disruptions in screening and diagnosis scenario, and black line represents the excess number of deaths when all disruptions are considered. As you can see, the effect of excess mortality accelerated until more or less 2025 and then leveled off. The graph also shows that the majority of the excess breast cancer deaths are due to the disruptions in screening and diagnosis according to the simulated scenarios. We also did some further analysis. First, we estimated what would have happened if the same level of effect of pandemic lasted for 12 months at the same level. And we found that if this were the case, the excess number of deaths would be approximately doubled. But by the way, there is now recent data that things are not as bad as what we did in this scenario. Secondly, we looked into the two scenarios. We first said, okay, what if all women who miss their mammograms skip mammography altogether until their next scheduled exam, whether it is 1 year or 2 years later, then there will be 1,600 excess deaths. And then we also said, what if all these women catch up their exams with a delay of 6 months? In 6 months, if they catch up, then this leads to 364 excess deaths. So this shows that skipping mammo would lead to, to be exact, 4.5 times more excess deaths than delaying mammography. So in summary, what did we find? We find that the impact of the initial pandemic-related disruptions in breast cancer care will have a small long-term cumulative impact on breast cancer mortality. And overall impact of disruptions in screening and delays in diagnosis of symptomatic evolution were more or less similar. And we also find that continued efforts to ensure prompt return to screening and minimizing delays in evaluation of symptomatic women can largely mitigate the effects of these disruptions. And especially impact due to the reduced screening during the pandemic could be mitigated by the facilities if they prioritize women who missed the screen during the pandemic. Of course, like many other modeling studies, we have some limitations. First of all, our treatment disruptions data was based on expert opinion, but there is, so the assumptions there may not be very reliable. We did a lot of sensitivity analysis, but there is a need for better data here. Secondly, there is limited knowledge on the screening and diagnosis behaviors during the pandemic. In other words, whether patterns in resumption of care are different between older versus younger women, or whether perceived cancer risk, and these may actually lead to different estimates. And finally, there was also an amazing question in the chat box. I noticed that, which is related to disparities. Unfortunately, disparities is a huge problem, like in many other services in breast cancer control too. And there are actually disparities in the resumption of breast cancer care services that we ignored in these analyses. And there are initial reports that there are some racial differences in terms of catching up the screening and diagnosis as of July 2020. So although the overall pandemic effect could be estimated to be relatively small, it may disproportionately impact women in underserved populations and exacerbate health inequalities. And if you want to read more about the details of this analysis, we just published this paper in JNCN just last month, so feel free to read it. And of course, feel free to reach out to me with questions and comments. And finally, I'm going to end by acknowledging and thanking my collaborators and Rakib for early feedback and our funding. Thank you.
Thank you so much. That was really interesting and informative, and I'm so glad that we have information that we can look at. So I'm going to ask the other panelists to turn their cameras back on. And also, thank you. Thank you. And I want to thank people who've submitted questions already, ask you to continue to submit. I'm going to get us started. And I know there was a question in the chat about disparities, and I also have a broader question. And to some extent, Emily, you addressed this in your presentation, that even if you did not specifically model disparities, you can use patterns of care or the models of patterns of care to try and inform what might happen in underserved populations. And I'm wondering if you could comment to that a little more. And then I'm going to ask the other panelists to comment to that as well.
Yeah, sure, absolutely. So I think for certain subpopulations, well, let me start by saying that our cervical model currently reflects kind of a national average risk population. So that's what it is built to reflect. There is an HIV cervical screening sub-working group of our CISNET group, and they are tasked with specifically doing similar analyses, but with models that reflect the burden in certain subpopulations. Kind of a next set of analyses will be stratifying our national level models to be reflecting certain racial and ethnic groups, but at this point we don't have those models. Though, as I kind of alluded to or said specifically in my presentation, our models are agnostic to currently race and ethnicity, poverty income level, education, and insurance status. But as much as these subgroups or underserved populations are correlated with certain behaviors. So screening less frequently, we can capture those screening behaviors in our models. So that's how we are currently trying to adapt and explore certain disparities within our national level models. But certainly the next steps will to adapt our models to more specific subpopulations.
Thank you. Would anyone else like to comment on that?
Yes, I want to add a few thoughts. So we didn't unfortunately model disparities in this particular model and exercise, but considering that pandemic hit the underserved populations more than the majority, so I can guarantee you that if we did an analysis, we would have found that disparities would have actually even become worse with the pandemic effect. So I think what we are presenting is really a best case scenario for underserved populations. And there are multiple facets to that. It's, of course, losing insurance and, maybe fear of the pandemic, because if these people live in areas where pandemic activity was much higher, especially in the summer of 2020. So I think, again, if you are asking as a modeler, if I ran the models, I would say, yeah, definitely would have had seen a much worse impact on these populations. So that I think I can only offer as an insight in terms of projections, unfortunately.
Thank you for that. I think it suggests to some extent that efforts to return to screening and to mitigate the effects of the pandemic should really focus on some of those populations that may be less likely to be screened or may have lost their health insurance coverage.
Yes, I actually wanted to reflect on that a little bit too, that although we haven't explicitly modeled the specific subgroups that might be vulnerable to this, we could look at the different scenarios that we have modeled and say which scenario is most likely for which population. And then if you look at a scenario where there's only a disruption and you assume that probably the high income people would be the first to be back to get what the screening day were due for, and then you compare it to a scenario where people just think, oh no, I'm not going to bother, I'm going to wait until my next moment, that could sort of give at least some idea of what might happen. Maybe some populations have more access to care, and so they will be able to catch up their missed screen within 6 months, whereas other populations will need 24 months to catch up their missed screen. And I think by comparing those scenarios that we've done, you can see what the impact would be, and that we have to put extra effort in these populations. And I think the analysis that Emily has done, where you show that if you have an irregular screening schedule, at least not up to date with the recommendations, that the impact is worse, I think that could be a good flag for policymakers to see that they should be getting those people in first. The ones that are delayed already without the pandemic, those are the people that we should be getting in first. I think those kind of information you can already get from the scenarios that we've run.
Thank you. Thank you. Rocky, would you like to add anything?
Well, just to say that we'll try, the program I work in also has the cancer registries, and we're trying to get through early EPATH reporting, early indications of the impact of the pandemic on incidence, and we'll hopefully eventually get that by race and ethnicity. So we'll see some of the downstream impacts of this and then try to work backwards through the models to see maybe why we've gotten some of those types of results.
I think that leads in really nicely to another question, which is, how will you be updating these models going forward? And I ask this as, of course, we're all watching what's happening right now with the Delta variant and the possibility of additional slowdowns, at least, in care delivery. So how are you all planning, or how will you be updating going forward?
I can actually just make a call for data and to help inform these models, but really I think it will always require multiple scenarios because the US is facing such diverse disruptions, and to certain, even in our cervical analysis, different steps along the screening pathway can be disrupted differentially. So I think in all of our analyses, we will always have multiple scenarios that we present because as Iris was saying, you can really pick the scenario that applies to your setting or subpopulation, or combining some scenarios to kind of get a picture of and bounding of the disruptions.
Yeah, I would like to echo Emily's comments or a request for data, because we are currently updating our analysis that we've done for the editorial of Dr. Sharpless and try to expand that. And we did a literature review to see what the impact of the pandemic had been on colorectal cancer screening and colorectal cancer diagnosis rates. And most data do not go beyond July. The data that Oz was presenting is somewhat more recent, but that's the only thing that we have to inform later disruptions. And so again, we had to model multiple scenarios. One where we assume, because in the first wave, you actually saw that the decrease in participation with screening and the decrease in diagnosis followed sort of the level of mortality that was going on at that time. But I don't think that's a realistic pattern for subsequent waves, because I think we've learned much better to deal with it. And you see that in the organized setting in the rest of the world, that yes, there was disruption of programs in the first 3 months, maybe 4 months. But although there have been subsequent waves of the pandemic that were sometimes exceeding that first wave, the programs have not been disrupted completely anymore. So we need data to inform those future waves, and we try to get the best. So if people have those, yes, we would be very open to them to inform our modeling.
I'll also just jump in again and just say, you know, these generic also coverage metrics are, while very important and helpful, Rocky spoke to the fact that these models really simulate individual screening histories. So understanding, as our second project really showed, that the length of time since a woman's last screen is really a good predictor of her future risk and her ability to weather some disruption. So data that could be provided on kind of the screening histories of women coming in, their last screening results, things like that. These models are pretty sophisticated and can, you know, incorporate all of these great data as long as they're available.
I'll just add that another consortium in NCI that CISNET works closely with is the Prosper Consortium, and that does works in different healthcare settings to collect data around the screening process. And that currently exists in cervical, lung, and colorectal. And there's a different consortium called the Breast Cancer Surveillance Consortium that Oz mentioned that works in breast cancer. And they're going to be working very closely with these consortia to, as data becomes available, to feed them into our models. But it's been sort of amazing seeing these talks. You know, when we did the initial work with Dr. Sharpless, it was very early in the pandemic. That editorial came out in June of 2020. And all we had to go on was assumptions. And now we're starting to feed gradually, you know, models could work on assumptions. That's kind of breathing thin air. And then as the air gets a little richer and we get more data, we'll incorporate those into the models. And I think, as Oz pointed out, the area where we still have the least data is disruptions in treatment. And that's going to be very important to see that.
Great, thank you. Thank you. Rocky, would you mind giving us a little bit of an update? I know I had the good fortune to be able to collaborate with some of your colleagues at the NCI to use the electronic pathology data from the registries. Could you comment on how up to date those data actually are?
I think, Robin, you could probably correct me, but I think that they've been able to do that data partly into 2021. So that's been fairly amazing and very quick, because I know the EPIC data, it took a lot of work to collate and bring it together, and it's a little bit behind. I think the EPIC data you used, I forget, you could comment, Oz, was through when, but we've been trying to do things very rapidly. Now, this won't have the quality of the regularly collected cancer incidence data that generally takes 2 years after the end of the diagnosis year to fully collate, but it'll be an early view of what's going on, and also seeing, as we've had various waves of this pandemic, does each wave correspond to the same sort of disruption in screening? And I thought, I forget who commented that it seemed like that first wave really was a huge impact, and the subsequent waves have not quite been as large, maybe because people are getting used to dealing with this. They know how to use telemedicine to talk to their doctor about, that's very important, to talk to their doctor to sort of assess, is it, you want to be prudent. Everybody wants you to get screened, but you want to be prudent. We need to talk and get medical advice in the balance. Is it safe to come in? And telemedicine is a great way to do that. So there seems to be some adjustment, and that people hopefully are trying to make rational decisions with respect to the risk benefit of coming in for screening.
Just to clarify, so as you said, we use EPIC data as of June 2020, and last month they published an updated report, and that goes until March 2021, and they found that even after 1 year, there was a 13% cumulative deficit in mammography screening, 21% in, I think, cervical, and 25% cumulative deficit in colorectal cancer screening. So even though there was some resumption of screening, still as of March 2021, compared to the pre-pandemic levels, there is still some deficit. And
but did they see?
I'm happy to share that.
Did they see a dip? I mean, we had that initial dip in April of 2020. Did they see there was a second wave? What was the second wave? Maybe November, December of
October,
2020.
November. October, November.
There was not
December.
another big dip
No.
then. That's generally what we're seeing.
Yeah.
If I can offer an international perspective on that, I don't know much for the barriers maybe in the US, but one of the reasons that we saw in the Netherlands this huge dip in diagnosis was, of course, the screening was disrupted, but also people worried to put extra pressure on the healthcare system at that time. There was big messaging going out that the hospitals were overtaken by COVID. So it was not only fear of infection, but doctors were taken off their usual wards, placed on the ICUs, et cetera, and people felt, so the number of people with cardiac symptoms and those sort of things also dropped because they felt that, no, this is not important enough to go to the doctor with. And I think one of the things that we've learned from that first wave is to avoid getting that message out, that people should not be delaying their visit to the doctor because they felt that what they had was not important enough. And that's really helped us also get back to the original levels again, because people felt that they shouldn't be burdening the healthcare system. And I think that's definitely something that we learned from the first wave that we could easily mitigate in the second wave. And of course, there was less panic. So the wards were kept open rather than closed, and everybody was moved to ICU. I think that's also changed.
Yeah, and I think one of the things that you all brought up that was so interesting is thinking not only about the disruptions in screening, but also disruptions in symptomatic detection. So, and that's exactly what, Iris, I think you were just reminding us, the importance of regular routine primary care for identifying maybe those early symptomatic presentations of some cancers, especially for those that may not have effective screening tests. I also wanted to comment a little bit. You mentioned the EPIC data, which for those who are less familiar, are electronic medical records from one of the largest providers in the United States. And so the EPIC, EPIC is used throughout different types of healthcare delivery settings, including integrated health systems, but also frequently used in federally qualified community health centers. So it is a more representative sort of picture of what might be happening. But, this idea that the disruption, in order to do a catch up, not only do you have to return to pre-pandemic levels of screening, you have to exceed those levels because you're getting people in who miss their screening. And I think that's a really important point that you all made so well. So I'm going to turn to some of the questions in the Q&A box, and it'll also give everyone else an opportunity to think more about their other questions. So there is a really interesting question about, has there been any analysis about how COVID deaths may mask excess deaths from cancer?
We actually did an analysis, and I'm going to pick up on Rocky because he insisted that you should do this analysis. And it's actually in an appendix table 14, 15 of the paper that we published. And as the, you know, and yeah, the referees gave us a hard time. They asked lots of analysis. But what we found is indeed breast cancer deaths drop due to the COVID-19 pandemic. But I want to caution that our analysis is quite limited. I mean, in the other sense, you know, normally patients who are undergoing chemotherapy and treatment, they are, you know, more immunocompromised, so they are more likely to die of, you know, COVID compared to other populations. So we didn't consider those factors. But even if we just adopt the COVID-19 deaths into our non-breast cancer cause mortality uniformly, we found that it actually leads to a reduction in breast cancer deaths. So the question is a very correct hypothesis. And again, we provide the numbers in our appendix, and you can see that. But again, I think the more accurate analysis will be if we can somehow put the effect on patients who are undergoing chemotherapy, because we didn't really specifically model breast cancer survivors in our models in this analysis, because then the masking impact will be even higher than what we would normally find. So,
yeah, that's a great. That I'm really glad that you included that in appendix number 14 or 15 in your paper. Has anyone else looked at? Have any of the other groups looked at that? The effect of COVID death on cancer-specific death?
We have not at this point. In a companion piece, actually, so the CISNET, through CISNET, kind of at the beginning of the pandemic, we published this analysis that was primarily focused on cancer incidence or cervical cancer incidence. We then, through the CCGMC that Iris was describing, we did a companion piece that included more countries and as well as additional outcomes, mortality, and but we have not looked at the masking, potential masking.
No, although I do know that the CCGMC indeed is not, so we are part of the screening working group, but working group 1 will be looking at these types of things, and soon there will be a link between these two working groups to try and see the joint effect. So I will put in the chat the website of the CCGMC, so people that are interested in seeing what is out there already, they can have a look, and everything that's published and all the work that we're working on will be updated every time there's something new on that website.
Great, thanks. So there's another really interesting question in the chat about, you know, how results from these models might be used in predicting healthcare staffing and appointment availability, and how this might be useful for healthcare systems so they can make accommodations for what you might think of as an influx of patients hoping to catch up on cancer screening. I don't know if anyone wants to take that one.
Well, I guess, if I go a little bit beyond the consortium, as part of the Dutch colorectal cancer screening program, we are the evaluating party at Erasmus. And this is exactly the type of analysis that's being asked of us. So we have some additional work in the pipeline where the Dutch government wanted to prepare for potential second or third wave. So this is work that we started summer last year, and we're currently writing it up. But we looked at, okay, what if capacity drops again? Should we disrupt the program again, or are there other ways to deal with a certain way of disrupting? And we looked at maybe increasing the cutoff for a positive test, or we looked at lengthening the screening interval for people, or maybe skipping some cohorts and not giving them, just skipping them one round. And we clearly found that the best thing to do from trying to reduce the excess number of deaths was to temporarily increase your screening interval. And that could last for 2 years, that would be fine. And then we could also show, okay, that means that you would require only so many colonoscopies. It would mean that there's so many additional deaths. This would be the average interval. And if you do not go beyond, so our interval in the Netherlands is 24 months. If you do not go beyond 34 months, that's the best thing to do. If you have to go beyond 34 months, then better also to increase the cutoff. So those kind of analysis, we have this direct link with the screening organization as evaluating party. And so this way we try to disseminate these results. In the US, it would be a little bit harder, I guess, to do because it's not a nationally organized program. And so it's different healthcare settings with different designs, et cetera, et cetera. But if there would be parties that would like to know this for their specific settings, I think that we could look at our the scenarios that we've run already and try to see percentage-wise what that would mean for those particular settings. I think it would not be possible for us to model all of the settings that are in the US, but we could deduct from what we've done, since we've run so many scenarios already, what could be the impact in specific settings.
And I'm gonna, follow up on what Iris said in the last point. So first of all, our models, they provide projections for the overall United States. So our models also projected how many mammograms we would need in 2022, 2021 in access to regular levels. So that could help for capacity planning. But when it comes to capacity planning and resources and things like that, then definitely state health system level, everything is very different. Deficit is different and pandemic effect is different. Things are different in Mississippi versus Wisconsin now, right? So I think it will be an overstretch of the models if you basically take our models and just like apply it uniformly to a particular health system. I don't think that the models will have any much reliability there. So, but I think with specific conditions, it's easily adjustable. But the way that these models are designed were not really to address what we call capacity planning, questions in the health systems and things like that.
One thing I'll just mention that has been a theme of CISNET is to maybe develop national models, but then in many of the groups and in this next round of funding that we're in, to develop state level models that are customized to the situation in different states, perhaps some of the capacity issues. And Iris in Europe has had a similar situation where they've tried to work with people and do modeling across Europe in countries in different countries with different settings. And similar in the US, we've done things with taking a national model. And I know they're trying to do that in this next round in cervical cancer specifically, is to get a state level model. And that's really what I think the unit, how you have to operate to work on capacity issues and things like that.
Yeah, I would just echo those sentiments. That's why we actually didn't do kind of capacity evaluations for the US with our national models. But you can use our models to look at the impacts of different disruption durations and get a sense of how long would be, do you have in terms of health impacts to try and catch up given certain capacity constraints within your settings. So I think our models can indirectly inform some of those decisions.
Mm-hmm. And so of course I have a related question it's about state, what's happening in some of the states, especially right now. I'm thinking of it as we're seeing what's happening with the wave of the new variant in some of the southern states like Louisiana and Mississippi. And, to what extent do you think some of the scenarios that you have that may have the combination of disruptions in screening, disruptions in symptomatic diagnosis, and also disruptions, at least in treatment initiation? I guess what I'm saying is, do you think there are some scenarios within some of your models that might be more applicable to some of the state settings right now? And I don't know if I asked that question very clearly, but I'm also thinking, for those who are really interested in trying to extrapolate beyond national estimates.
Your question is crystal clear and an excellent question. It's just the answer is not easy. That's why I think we are hesitant to respond. So yes, you could. I think at least our analysis, the scenarios, we did just like one-time thing. We didn't consider this like multiple waves type of a scenario in none of our scenarios. That's why I'm hesitant to say, okay, suppose I replicate cases in Florida, where things were better in the initial March to June, things weren't as bad as things in New York, right? New York was much worse in terms of pandemic effects. and now you have a second wave, third wave. None of our scenarios consider that type of a scenario where the first wave makes a huge dip, it resumes, and then you have a second dip. You could, in theory, model that. I mean, these models are complex but very flexible. We could model that given the data. I think the challenge there is really the context of the state. Like, do we have the right levels of screening practices in that state to inform the model so that, you know, our estimates are not going to be just like nationwide screening rates. And especially in some of those places, there is some of the disparities could be even wider than what we use in our, you know, national data. So all those things are making me a little like hesitant to say, oh yeah, we can do it, or we have already considered that.
I'll just say one thing we learned during the COVID pandemic is, you know, mostly there's some infectious sort of element in cervical cancer, but mostly, you know, in cancer, things don't happen so quickly. So we have a pace of our modeling, but through the pandemic, we realized that, and some of the people in CISNET, I know Oz was intimately involved, it did direct COVID modeling, and you realize this pace, and we had people in one of our plenary sessions and talk to them about the pace in which they had to do their modeling. And that pace is just so much faster than we've done. We've done very deliberate and very high quality modeling. And it's been interesting to watch the COVID modelers. And we never saw so many modelers on TV as during the pandemic. And I thought, oh my gosh, but the pace that they do that, and how do they do that? And I don't know, if you want to comment on the pace that you had to do the COVID modeling and what that taught you about the speed at which we need to do things. So for example, to address the question that Robin indicated, well, first of all, we don't have much data, but also for future waves and the Delta variant, but how do you do the modeling so quickly and still be careful?
Yeah, I mean, as Rocky said, I did, and I am still doing a lot of COVID-19, like infectious disease modeling. I work with our health system, and they first contacted me March 19, and they said by April 1st, we need a model on predicting COVID-19 cases and number of beds, ICU and ventilator needs within, our region in 10 days. So it took us 5 years to develop a breast cancer model, right? And they asked me in 10 days. So I think, of course, my lesson is, of course, the models are, CISNET models are, I always say, like, models are like a car. You can drive a Ferrari or you can drive a Camry. I have a Camry, by the way, and they both serve the purpose of you are going to a racetrack, you want to go with a Ferrari. And CISNET models, in my opinion, are like Ferrari type of cars. Like my COVID model, with all the models, it's like a Toyota Camry. It does the purpose, it's simpler, and you are, of course, we are doing less calibration, less details. That's what happened in most of the COVID, models. And that's why initial models, some of them are like wildly wrong. And CISNET models, if you look into them, they are more or less stable. Over the years, very good justification, even if they make a change. But so I think, but what COVID taught us is we should really find a way to come up with these quick, solutions, because there is a strong need. And sometimes, providing an answer 6 months later is really obsolete. It doesn't make much sense. So yeah, I think we should probably think about that. But unfortunately, I don't have a really great one-line take-home message for you, Raki, to do quick modeling now. Sorry about that.
So I am going to then, since we don't have the quick take-home how to do this, with high quality, speed, and real-time data, I am going to ask you what your priorities are going forward in terms of using models to evaluate the effects of the COVID pandemic.
I actually might jump in here and kind of as a follow-up to the previous question, might tie into this next one. But when we were first setting out and to do some rapid response, we wanted to bound the problem. Like, you know, we chose disruption periods that were from 6 months to 24 months. And that really covered the spectrum of maybe what the future may hold. And we'd say, well, maybe it's going to be 6 months, maybe it's going to be 24 months. And if there's any intervening oscillations or you know, pandemic waves, you could even say, well, pretend nobody screened for 24 months, what would that look like? And so even though our scenarios might not reflect, and you would go to a modeling paper and say, well, this is not exactly what's happening in my setting, I think I would like to challenge everyone to kind of say, well, are there aspects of these scenarios that I could apply to my setting and maybe take an extreme, you know, the extreme scenarios and say, well, this may, at least I know it won't be this bad, right, in my setting. So, and if it's a 24-month disruption to everybody, here's what I would expect. And so, even though we can't reflect the real-time data that are coming out often, if they're unavailable or to locate, you know, location specific, I think there are scenarios that we try to pick that would reflect bounding what we might see. Yeah.
Yes, and to add to that, within the Global Modeling Consortium, we're currently trying, because we have 4 models for 3 countries, and we actually want to estimate it for, well, the whole world. It's a little bit ambitious, but at least organized programs across the world. And we also are trying to incorporate the most important non-organized program, which would be the US, to try and at least get, for the biggest colorectal cancer screening programs across the world, some impact on what it might be. And there we also have to take shortcuts because we do not have the data for every country of what actually happened, et cetera, et cetera. But the idea would be that, again, we adjust our models on very simple levels. And we also sort of cross-validate against each other's programs to see how far off we are if we use the Dutch model for the Australian situation, et cetera, et cetera. But that's the idea that we're going to move forward. And I think if that gives promising results for a global level, maybe this is an approach that we as CISNET could also take for a state level within the US. So I think that's one of the things that we could learn from that analysis. The other important part that we're going to look at is there is joint initiatives from the International Cancer Screening Network to try and do a quantitative data survey among screening programs across the world, at least the ones that we have contacts with, to really get quantitative estimates of what the impact of COVID-19 has been on not just the screening, but also some of the outcomes of the screening, so that we can validate what we've been predicting so far with our models against real-time short-term data. Because if we're wrong on the short term, we're very likely to be wrong on the long term. So that's the additional step that we also want to make sure that what we're predicting matches with what we are seeing in the short term.
Well, you know, I hate to do this because I'm enjoying this conversation so much, and I'm sure many in our audience are as well. But we are very close to our time. I want to invite Caleb Level to come on and give us some wrap up in terms of next steps. I know you've received some comments through the chat about a survey. Any other closing comments? But before you go, Caleb, thank you all so much. This was fantastic. So interesting. I think we all learned a lot. Thank you.
Yeah, and I just want to pile on the thanks is really the only reason I wanted to come on. So I want to thank all of our panelists for the time that you spent to prepare for this and help us coordinate it. Also want to thank ACS staff that helped coordinate this session, Stacey Fedewa, Megan Burns, Dion Christopher, Sarah Schaefer. And a special thank you to Dr. Yabroff for being our moderator today and really navigating this conversation and hosting a great discussion. And then obviously a thank you for all our attendees who participated. You know, we knew we were being ambitious, asking you all to stick around for 90 minutes with us today. But I think it was worth it because there was so much great information that we've been able to share. So really appreciate that. Please do fill out the evaluation that you have in the link in the chat. We will be sending out an email so that you can follow up on that as well. Please do save the date for our next webcast, which I promise will be just as interesting and conversation stimulating. It's on September 9th, 1 to 2:30 p.m. Eastern. And we'll be sending out a registration link to all those that were able to register and attend this. And there will be a recording, and we'll share as much of the slides as our panelists will let us share, getting their permissions and things. So please do be looking out for some emails from our team at ACS on evaluation, follow-up, things like that. And we appreciate everybody's time today. And thank you again, panelists. It was fantastic.